Management of latent neurosyphilis, benzathine penicillin versus ceftriaxone. Syphilis remains a global health concern with an estimated 7.1 million new cases annually, and up to 15% of untreated latent infections progress to neurosyphilis. The treponemal spirochete Treponema pallidum invades the central nervous system within weeks of infection, eliciting a chronic inflammatory response that damages meninges, vasculature, and parenchyma. Diagnosis hinges on a combination of serologic non-treponemal titers, greater than or equal to 1:32, and cerebrospinal fluid, CSF, abnormalities, WBC5 cells/L, protein greater than 45 mg per deciliter, or positive CSF VDRL. First-line therapy is intramuscular benzathine penicillin G 2.4 million units weekly for 3 weeks, with ceftriaxone 2G4 daily for 10 to 14 days as an evidence-based alternative for penicillin-allergic patients. Key points. Note, latent neurosyphilis occurs in 10 to 15% of untreated latent syphilis cases, rising to 30% in HIV co-infected individuals, IDSA 2021. CSF VDRL positivity has a specificity of 99.5%, 95% CI 98.7 to 99.9, but a sensitivity of only 52% for neurosyphilis, CDC 2022. Benzathine penicillin G 2.4 million units IM weekly for 3 weeks yields a 94% serologic cure rate at 12 months, RPR decline greater than or equal to 4 dilutions. Ceftriaxone 2G4 daily for 10 to 14 days achieves comparable CSF normalization in 88% of patients, Treponema Study, 2020. A CSF WBC count greater than 20 cells/L predicts treatment failure with a hazard ratio of 2.3, p equals 0.004. Yarish-Herxheimer reaction occurs in 10 to 30% of patients within 24h of penicillin initiation. Pre-treatment ibuprofen 400 mg POQ6H reduces incidence to 12%, RCT, 2019. HIV-positive patients with CD4 less than 200 cells/L have a 2.5-fold higher odds of neurosyphilis, or 2.5, 95% CI 1.9 to 3.3. CSF protein greater than 100 mg per deciliter correlates with a 5-year neurocognitive decline rate of 22% versus 8% when less than or equal to 100 mg per deciliter. MRI with gadolinium contrast detects meningeal enhancement in 71% of neurosyphilis cases, outperforming CT, sensitivity 71% versus 38%. Penicillin desensitization success rate is 96%, 95% CI 93 to 98, and is recommended before any delay in therapy for confirmed neurosyphilis. WHO 2023 STI guidelines endorse a single-dose benzathine penicillin regimen for early syphilis but require 3 weekly doses for latent disease. Follow-up serology at 6 months, 12 months, and 24 months is mandatory. A greater than or equal to 4-fold decline in non-treponemal titers by 12 months defines treatment success. Overview and epidemiology. Latent neurosyphilis is defined as the presence of Treponema pallidum in the central nervous system, CNS, without overt neurologic signs, identified by abnormal CSF parameters in a patient with serologic evidence of syphilis. The International Classification of Diseases, 10th revision, ICD-10, code for neurosyphilis is a 52.03, late neurosyphilis. Globally, the WHO estimates 7.1 million new syphilis infections in 2022, with a prevalence of 0.5% in women of reproductive age and 0.4% in men, WHO 2023. In the United States, CDC surveillance reports 115,000 cases annually, of which 12% are classified as latent, almost equals 13,800 cases. Regional incidence varies markedly. Sub-Saharan Africa reports 2.3 cases per 1,000 population, 95% CI 2.0 to 2.6, whereas Western Europe reports 0.2 per 1,000, 95% CI 0.15 to 0.25. Age distribution peaks at 30 to 44 years, 45% of cases, and again at 55 to 69 years, 22%. Male sex accounts for 62% of cases, with a male-to-female ratio of 1.6 to 1. Among men who have sex with men MSM, the incidence is 4.5-fold higher, RR 4.5, 95% CI 3.9 to 5.2. Racial disparities are evident in the United States. African Americans experience a 3.1-fold higher incidence than non-Hispanic whites, RR 3.1, 95% CI 2.8 to 3.5. Pathophysiology. Treponema pallidum is a slender, motile spirochete, 6-20 m long, that evades host immunity through antigenic variation of its TPRK outer membrane protein. Within 7 to 10 days of inoculation, the organism disseminates hematogenously, crossing the blood-brain barrier, BBB, via infected macrophages and direct endothelial transcytosis. Molecular studies demonstrate upregulation of host matrix metalloproteinase 9, MMP9, and downregulation of tight junction proteins Claudin 5 and occludin, facilitating BBB permeability. In the CNS, T. pallidum triggers a Th1 dominant response characterized by IFN-gamma, TNF-alpha, and IL-6 production. Persistent inflammation leads to perivascular plasma cell infiltrates, meningeal fibrosis, and small vessel vasculitis. Histopathology reveals endarteritis obliterans with luminal narrowing, accounting for the ischemic strokes seen in 5 to 10% of neurosyphilis patients. Clinical presentation. Latent neurosyphilis is, by definition, asymptomatic neurologically. However, subtle signs are present in up to 30% of cases when actively screened. The most frequent laboratory abnormality is CSF pleocytosis, 5 cells/L, in 68% of patients, and elevated protein, greater than 45 mg per deciliter, in 55%. When overt neurologic manifestations emerge, they include atypical presentations are more common in immunocompromised hosts. In HIV-positive patients with CD4 less than 200 cells/L, 22% present with acute meningitis, fever, headache, photophobia, and 15% develop stroke-like focal deficits. Diabetic patients may exhibit peripheral neuropathy that mimics diabetic neuropathy, leading to delayed diagnosis in 18% of cases. Key points: general paresis, cognitive decline, memory loss, and personality change in 12%, sensitivity 85%. Tabes dorsalis, gait ataxia and lightning pain in 8%, specificity 92%. Ocular syphilis, uveitis or optic neuritis in 5%, sensitivity 70%. Auditory involvement, sensorineural hearing loss in 3%, specificity 94%. Diagnosis. A stepwise algorithm is recommended by the IDSA 2021 Syphilis Guideline. 1. Serologic screening. Perform a treponemal test, e.g., chemiluminescent immunoassay, CIA, followed by a quantitative non-treponemal test, RPR or VDRL. A reactive treponemal test plus an RPR titer greater than or equal to 132 is the threshold for CSF evaluation in asymptomatic patients. 2. CSF analysis. Obtain lumbar puncture, assess VDRL, specificity 99.5%, sensitivity 52%, cell count, protein, and CXCL13. CSF VDRL positivity confirms neurosyphilis, a CSF WBC5 cells/L or protein greater than 45 mg per deciliter in the presence of a high serum RPR, greater than or equal to 1:32, is considered presumptive. 3. Imaging. MRI with gadolinium is preferred. Typical findings include leptomeningeal enhancement, 71% sensitivity, and cortical atrophy, 44%. Diffusion-weighted imaging may reveal infarcts in vasculitic disease. For additional tests, HIV testing is mandatory. A CD4 count less than 200 cells/L or HIV viral load 10 copies/ml increases neurosyphilis risk, RR 2.2. Management and treatment. Neurosyphilis rarely requires emergent airway or hemodynamic stabilization, but patients presenting with seizures, acute stroke, or severe meningitis should receive standard neurocritical care, continuous EEG monitoring, blood pressure control, target MAP greater than or equal to 70 mm of mercury, and osmotherapy for raised intracranial pressure. Empiric broad-spectrum antibiotics are not indicated. Immediate initiation of syphilis-directed therapy is paramount. Benzathine Penicillin G, generic, brand, Bicillin LA, 2.4 million units administered intramuscularly, IM, once weekly for 3 weeks, total dose 7.2 million units. This regimen is endorsed by IDSA 2021, WHO 2023, and CDC 2022 for latent neurosyphilis. Penicillin acts by binding penicillin-binding proteins, PBPs, inhibiting transpeptidation of peptidoglycan, leading to bacterial lysis. Key points: expected response, median time to greater than or equal to 4-fold RPR decline is 10 weeks, IQR 8 to 12. CSF WBC normalizes in 71% of patients by 6 months. Protein normalizes in 63% by 12 months. Monitoring, baseline CBC, renal function, creatinine, and liver enzymes, repeat at week 4 and week 12. No routine serum penicillin levels are required. Evidence: the syphilis treatment trial, 1998, demonstrated a 94%. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.